To speak on the topic of MS Healthy Brain and Time Matters is Professor Gavin Giovannoni, who is Professor of Neurology at the Centre of Neuroscience and Trauma, Blizzards Institute in Barts, and London School of Medicine and Dentistry. We saw him yesterday, and trust me, this is important stuff. A little bit frightening, but also very important. So, Professor Giovannoni.
Thanks. Well, thanks for inviting me to talk to you about this very important topic. I'm wearing a T-shirt that says Think Hand, and it's a campaign we're actually launching. We launched at Electrons last week, which is the big MS meeting. And the reason why we launched it is that we think people with more advanced MS will benefit from treatments because it will protect their upper limb function. And we have some very, very good data from a lot of clinical trials showing exactly this, is that even though people may be more advanced and have lost function in their legs, they still have their hands to protect. And we want to start a clinical trial to try and show that definitively that even in people in wheelchairs, we can actually modify the course of their disease. So that's the Think Hand campaign. Maybe you can support it. Just I've got a lot of disclosures. I have put this presentation online already, so you can download it from our blog afterwards. You can get the slides if you want them. And the reason why I've got a lot of disclosures is the centre I work in and run, we're very, very active in doing clinical trials. So the question is, we've all got a brain, and who's responsible for looking after that brain? Is it you, the person with the disease? Is it the neurologist or the healthcare professional? Is it the healthcare system, the regulators, the people, in other words, licensed therapies for multiple sclerosis? Or is it society in general that does this? And I'd argue that everybody's responsible. But today's talk is about activating individuals to take care of their own brains or help take care of their own brains. And so we now know in multiple sclerosis that there are two things that dictate outcome in terms of brain health. Now, we're all going to get old, and I said this yesterday, that life itself is a sexually transmitted neurodegenerative disease. In other words, everybody who lives long enough will get age-related cognitive impairment. It's just a fact of life. Most people are fortunate enough to die of other causes before they become demented. But if you don't die of natural causes and you live long enough, almost everybody develops cognitive impairment. And the simple reason is that evolution never designed us to live to the ages we're living. And that's an important aspect because people with MS are going to get old. And what protects them from age-related problems is how much brain they've got. And there are two components to brain health. It's the size of your brain and how much reserve you've got in terms of cognitive reserve. And so cognitive reserve is about environmental enrichment and education. There's brain exercises. So there are two things we need to do. Is we need to optimize therapies to protect the size of the brain. And then we have to optimize our life to make sure we maintain our cognitive reserve. In other words, keep our brains active. And this is what we're trying to prevent in MS. So these are two examples of patients who were studied in an MRI scan. I want you to see those black holes. Those are the big ventricles inside the brain, and you can see what happens at baseline. That's 18 months later. Baseline, 18 months later. In other words, people with MS brains shrink because of their MS. The MS damages the brain. And we know this occurs at a much higher rate, on average, than in people who are normal. And so I'm saying who are normal because after the age of 35, everybody's brain shrinks. It's just a fact of life. By around about 0.2% per annum. And people with multiple sclerosis brains shrink probably 2 to 7 times that rate, depending on how active their disease is. And now we have treatments that can actually slow or get rid of that process as well. So when does this occur? And so this is actually a study that was done in Europe, looking at different sets of people with the disease. This is clinically isolated syndrome after the first attack, relapsing and progressive. And you can see those orange boxes as the rate of brain loss, and that's common across the early and the late phases of this disease. So this process is part of what's there all the time. And it's important to realize this, is that these people over here don't have clinically apparent progressive disease. And so what's protecting them from having progressive disease is what we call reserve. They compensate. You compensate for the damage until you've lost the reserve, and that's when you get the progressive phase of the illness. It comes out. So I actually have been telling people that there is no magic switch point between relapsing and progressive disease. The process is there from the beginning. What dictates where you turn over is how much reserve capacity, in other words, how much cognition you've got to protect yourself. So this is just a very scary figure, and it's just been updated in 2016, and the results are pretty much the same as they were when this was done in 2004. This is looking at employment rates and disability, and we measure the disability using this thing called the EDSS, Expanded Disability Scale. You must have heard about that. And you can see when people are at 3, half the population in Europe are unemployed. Now, people who have got an EDSS of 3 look normal when they walk through the door. So this is not physical disability that's driving this. What's driving this is almost certainly problems with cognition and memory. And when you actually interrogate people who present with their first clinical event, almost half of them already, or a little bit more than half, already have problems with cognition. And when you actually interrogate the cognition, it's usually memory function, how quickly they think, attention and executive function, performing multiple tasks. And that's probably why people become unemployed early on in the disease, is because we're in the knowledge economy and we require our brains to do all these multitasking, and people just can't cope with that in the workplace. And so they don't complain of cognitive problems. What they complain about is cognitive fatigue. Because to achieve the cognitive output, you've got to work so much harder than somebody who doesn't have multiple sclerosis to achieve this. I see people nodding and shaking their heads. I think they will relate. A lot of people relate to this in the audience. So this is why we have to treat the disease early to protect them. So this is my worldview. I live in London, so this is the London tube map, and I kind of put it on, I kind of view the disease as a journey where you go from early in the disease through the different phases of impairment, and as you get more disabled from the MS, you pick up all these symptomatic problems, bladder, bowels, balance, etc. And so I, myself as a neurologist, spend most of my time treating all these symptomatic problems. That's what happens in the consultation, fixing up all the problems as a result of the damage. And the real message is if we can treat this disease very early and stop that happening, we will prevent all that from. And that's what this whole brain health thing is about, how we treat this disease effectively early. We also know now what causes this process is almost certainly the inflammation in the brain. And we know that MS causes these multiple lesions, and you can see these little white blobs here. That's when you have an MRI scan and they give you the contrast agent, gadolinium. And when the lesions are inflamed, they light up white. And we know under the microscope that inside those lesions there's lots of damage occurring. You see that nerve fiber there being cut like with a pair of scissors. You see that bulb? It's like a retraction bulb, and that nerve fiber is going to die. And that causes the acute relapse, be it optic neuritis or whatever. And then also in that lesion there are nerve fibers that aren't cut, but they're damaged. And they may repair themselves, but those nerve fibers are never back to normal. And we think they're programmed to die off early later on. And so we think that inflammation drives both processes, acute, sudden onset relapse, and then it sets up the surviving nerves to die off over time, and it causes the progressive phase of the disease. And so the obvious logic of that is if we want to prevent MS getting worse, we've got to switch off as much inflammation as possible, all of it if we can. And there's now very, very good data just showing you this is now what we call a meta-analysis, where you take all the trials and you add them together. And in that you can see that lesions on the scan predicts about 61% of disability. Shrinkage of the brain over year 2, about 48. And when you put those two together, the so-called inflammatory component of MS and the degenerative component explains about 3/4, 75% of disability. So the message from all our trials is to optimize or maximize outcome, we have to switch off inflammation, no new lesions, no relapses, and we have to normalize shrinkage of the brain atrophy. And if we do that, then people should, theoretically, based on these observations, their brain should age as in the normal range. Now, what about relapse reporting? So in the past, we used to say to people with MS, you can have a relapse. These drugs we're going to put you on are partially effective. That's not true anymore. We now treat to a target and we try and suppress all inflammation. So we need to make you relapse-free. attack-free. And so that means if you are having relapses on a particular treatment, that may mean the treatment's not working. And the problem we have in the UK is that not everybody reports relapses. So in this particular study from Newcastle, in the last year, 28% of subjects didn't report having had a relapse in the last year. Because they were mild or moderate relapses, they just lived through them, and when they came to the annual assessment, when they were asked, I had a relapse 4 months ago, but I didn't worry about it. That's not, in the current treatment paradigm, that's not acceptable. We would like people to be relapse-free. Isn't that a change compared to in the past? It's a big change. So we need you to report relapses. The other thing we try and do is stop progression of the disease, and we use this thing called the EDSS. You've all seen this score. Huh? When you need a stick, it's EDSS 6, and a wheelchair, it's 7. And when you start having walking affected, it's EDSS 4. Now, the problem about EDSS, and I see Dr. Sweeney sitting here, is that we don't do it in clinic, because it takes about 20 minutes to do this properly, and then we have to walk you for 500 meters as well, if you can walk. And we just don't have time in routine clinical practice. And just to say to you that in the United Kingdom, 75% of neurologists don't do the EDSS. And even when they do the EDSS, very few of them walk their patients. So it's not been done properly. Not been done properly. So what we've tried to do is we've tried to activate people, and we created a little website called Clinic Speak. And on the Clinic Speak, there's a little questionnaire that you can log in. It takes about 2 to 5 minutes to complete, depending on how MS has affected you, and it gives you a good estimate of your EDSS score. And we've actually validated this against neurologists, and it validates very, very well. So if you want to know your own EDSS score, you can go there and do that. And we've also just added a new one, which will also allow you to log your scores, called the 9-hole peg test. The 9-hole peg test is a test function for upper limbs. And we launched it at ECTRIMS. We hand out these cardboard 9-hole peg tests to people. And we give you a little instruction video on how to do it. And you can measure your own speed of movements. And we'll also be putting instructions on how to do your own timed walk. So we're going to be hoping people with the disease can measure those 3 metrics. How fast they can walk, how good their hand function is, and the EDSS score. And the reason why I'm putting those 3 up is because those are the metrics, the measures that we in neurology use to monitor MS. And why do you need that? Well, the good news is, at ECTRIMS, there were 2 sets of results presented. One was a drug called ocrelizumab. This is a new therapy that's going to be given every 6 months as an infusion. And for the first time, we had a positive trial in primary progressive MS. Isn't that amazing? So there's a treatment coming for people with primary progressive disease and reduced disability progression by approximately 25%. Interestingly enough, it reduced disability progression in the upper limbs by even more, 45%. So this drug's even more effective in protecting the upper limb than the lower limb in people with primary. The reason for that is there's more reserve in the upper limb than in the lower limb, and that's what the reserve allows you to recover function. A drug for primary progressive disease. And at the same meeting, we had a drug called saponamide, and this drug was also shown to be positive, but not in PPMS. This is in secondary progressive MS, and it reduced progression of the disease by about 21%. Now, that may not seem like a lot over 2 years, but if you take this to 4, 5, 10 years, that 20% may become 50 or 60%. So this, over time, these little differences can be a big difference. Now, the important thing about these trials is to get into those trials, people had to have had progressive or actively progressing disease. And they had to be in the notes, objective evidence that their disease was getting worse over 2 years. And I think almost certainly if these drugs get through the NHS or get available to you, you're going to have to show that your disease has been getting worse over the last year or 2. And if you can't rely on your neurologist to do the scoring system, you're going to have to do it yourself. So I think people with the disease are going to have to produce the evidence. My disease is getting worse if I want these treatments. So by measuring your disease progression yourself, you'll have that information. Does that make sense? So if you start tracking your own disease, there's 3 scenarios. You actually improve. Isn't that good? If you stay the same, not too bad. Your disease is stable. But if you're getting worse, it could be very depressing. But that's what you need to take to a neurologist, take to Dr. Sweeney and say, I'm getting worse. What can you do about it? And he's going to say, well, there's some therapies coming. He may be able to put you in trials. And maybe we'll be able to prescribe those therapies. So that's why we're trying to activate patients to monitor their own disease. Risk benefits. So one of the things as neurologists don't do is we don't tell you how bad MS is. And all of you looking at me will probably know how bad MS is. And some people who get newly diagnosed patients are very rarely told about the impact of MS on average. And I think you need to know that information if you're going to have to make decisions about the future. You need to know how bad MS is so that you can actually make a decision about treatments. And so we have also put together a little infographic that just tells you how bad untreated MS is on average. And I think people need to know this up front to make decisions about which treatments they want. And this is why we promote early treatment. So somebody who's got their first attack and is relatively well, may go into denial and not want a treatment. But if you manage to educate them and explain how bad MS can be, they may make different decisions up front about their therapy. And so the old paradigm, where we used to let people go on to therapies and then switch them and cycle them through what I call the lower efficacy drugs before moving up to the high efficacy drugs, I think is gone. We're now in an era where we're actually more active, and we monitor and we shift up quickly, and we're adopting the same principles that have come from rheumatology, the rheumatologists who treat rheumatoid arthritis. And similarly, this is a slide from gastroenterology. These are the doctors that look after inflammatory bowel disease, the autoimmune disease of the gut. You may have heard of Crohn's disease, how they treat Crohn's disease, or ulcerative colitis. So the old approach, where you have the conventional step up, is gone, and now we have the accelerated step care, and we actually have this other one where we flip the pyramid. In other words, if somebody's got a bad prognostic profile, looks like their disease is going to do badly, we give them the most effective drugs first line to give them the most impact in the beginning, and that's called flipping the pyramid. And we started doing this in our centre now. About 40 to 45% of our patients are going on to the most effective therapy first line. And the reason why we can do that is because NHS England has given us the opportunity to use the most effective therapies first line, and that's where they're the most cost effective, the earlier you use them. There's been a study done in Norway about cost effectiveness, and the most effective therapy we have at the moment has been shown to be the most cost effective therapy. And so that's an argument in itself to want to use those treatments first line, or at least offer them first line. So this is an example of two patients I mentioned yesterday. They're both MS champions. They're out of the MS closet. They publicized their MS to the world. One of them is a professional golfer called Tony Johnston from Zimbabwe. He lives in England. He's now in his late 40s. And if anybody watches Fox Sport, he's one of the pundits on Fox Sport for golf. I saw him when I was at Queen Square National Hospital way back in 2002 when he had his first 2 attacks, and he was at EDSS 3.5, so he had some upper limb problems and balance issues. I sent him off to Cambridge, and he was given alemtuzumab, a drug called Lemtrada, that's available in Ireland as well. He had 2 courses. He went into long-term remission. He's had no evidence of activity since then, and he's got back to 0 on his score, and he's playing professional golf again. And so the last time I spoke to him on the telephone, which was about a year ago, I phoned him up, and I said, "Tony, how are you doing?" He said to me, "I'm absolutely fine. The only symptoms I get is on a very hot day, if I play a round of golf, I may get pins and needles in my hand." Isn't that an amazing story? And I tell you, his scan was really bad. He had quite a lot of bad prognostic features. Very similar to him was another person called Ian Rogers. He's a statistician. He works for the National Auditing Office in London. And he spends his life doing research. He runs a big team of people that do research. And he does very detailed research for parliamentary committees. And Ian came to me for a second opinion after having had 2 attacks with an EDSS of 1.5. And he wanted to go to Ottawa in Canada to have a hematopoietic stem cell transplant. He wanted a bone marrow. I spoke him out of it. I said, it's just far too dangerous. The risks of dying are too high. And I spoke him out of it. But I said to him, don't worry, we could send you off to Cambridge. They were using alemtuzumab, Lemtrada, under a compassionate use program in Cambridge. And he was accepted onto the compassionate use program. But the Monday he arrived there, Alistair Coles came out and said to him, "Ian, I'm terribly sorry we can't treat you. We've stopped using alemtuzumab compassionately." And the reason for that was in the trial that had been running, one of the patients died of an unfortunate cerebral hemorrhage from a complication of the treatment. They got a low platelet count. And so he didn't get it. He came back to me and we put him onto an interferon, and he had 2 devastating relapses on interferon, and he ended up in a wheelchair. He recovered function back to a walking stick. Unfortunately enough, they reactivated a trial in Cambridge for alemtuzumab, and he managed to get onto a trial and get treated on the trial. He had his 2 courses. He's been activity-free since then, no relapses, and his MRI has been quiet. But he never got back to baseline. He recovered to a 3.5, and he's been like that ever since. He's had complications of the treatment. He developed autoimmune thyroid disease or Graves' disease, and he's had quite a bad bout of shingles, which are a side effect of the treatment. And he's back to EDSS 3.5. Now, some people would say, well, that's a good result. But for Ian, it's not. 3.5 means he had to stop running. He used to run marathons and half marathons. He can't run anymore. And he can't play tennis anymore. He belonged to a tennis club. So he's had to take up cycling. And what upsets him most, he can't run down escalators. And if you work in London and you want to get home quickly, you want to run down escalators, okay? And so you could argue that's not such a bad outcome, but for him it's really had a big impact on his quality of life. And the difference between these two is simply an 18-month delay in access to treatment. So for individuals, time does matter. He wanted his treatment up front and didn't get it. So we're trying to create this concept that time does matter, just like in stroke. If you wait too long, you can have a bad relapse, or the MS can be active without you being aware of it, and that could be actually chewing up and reducing your reserve. And so we're trying to activate the community to treat MS much more timely. And this brings up my colleagues. Brian, I don't think you're in the same class as this, but I'll explain to you about this. So there are people who adopt things very quickly. We call early adopters, and I think Brian's an early adopter. And then you get people who are laggards, okay? And then you get people that are late adopters. And this is called the adoption curve. It's how you adopt a new innovation. A new drug comes out, how quickly do you start prescribing it? And the problem is when you have waves of innovation, the difference between certain neurologists and other neurologists is enormous, or certain countries and other countries is enormous. And we can actually measure this. So this is the ruler, number of people who are eligible for treatments. The black line is the number of people who are on treatment, and the orange line is the number of people who are on second line or third line or more effective therapies. And when you look at Europe, this is done in 2013, it's improved slightly. You'll see that there's incredible variation across the world, across Europe. So the UK is second from the bottom. Only 20% in 2013, only 20% of eligible people in the UK, 1 in 5, were on a treatment. In Germany, it was about over 70%. But the orange bar is even more scary. In the UK, only about 5% were on a second line more effective therapy. And in places like Australia and Norway, it's a third. So we're not, clearly this variation is saying that some people are adopting the innovations much quicker than others. And so this is not, I don't know where Ireland is. Where do you think Ireland will be on this list?
I think we probably have about 4,000 or 5,000. We have 9,000 people who have MS, and I think at the moment there are about, as far as I know, about 4,000 or 5,000 people on treatment.
So you'll be in the region of Australia. Yeah, so Ireland is probably adopting therapies much quicker than the UK. And this will have an impact on outcomes. Clearly, if you're going to have MS, you want to be in a country where there's much higher penetration of these treatments. And also, the proportion of patients on a second-line treatment must also be a quality metric, because a certain proportion will have to be on more effective therapies. We know a large number of people break through on the so-called first-line or platform therapies. And they're breaking through because their disease is remaining active. And so a certain proportion are going to have to be on a higher efficacy therapy as well. And so that's an important metric as well. So what we did was we created a policy document, this initiative to try and highlight these issues, and it's called Brain Health, Time Matters in MS. And we've got now over 35 various organizations that are linked to MS that endorse the document. MS Ireland is one of them. We've got multiple sclerosis societies from across the world. We've got the CMSC in the United States, ECTRIM. So all the big stakeholders support this document. And so that's a very important message in itself. We as the community think the message we're trying to get across in this document is critical to improve the management of MS across the world. And really it's just common sense. It's how do we get people into the system very quickly, so getting general practitioners, family doctors to refer in very quickly. It's getting diagnosed quickly, it's getting onto treatment quickly, and it's monitoring and shifting to more effective therapies where necessary. It's also collecting data, it's involving patients in shared decision making, and it's also focusing on other aspects that improve brain health, like the lifestyle issues. So this just covers all the things I'm talking about in this lecture in a policy document. And the whole concept of the policy document is to shift the intervention earlier. In other words, protect reserve, so long-term outcomes are better. It's about protecting reserve, making sure we keep the brains as large as possible and keep your cognitive reserve as large as possible, because you're going to need those when you get older. People with MS are going to age just like the general population, and we need cognitive reserve to age healthily. So I put this up. This is a personal story because this is an example of why we in the field of MS are lucky in a way. So this is a person on renal dialysis. My father had chronic renal failure and was on dialysis for 12 years, then had a kidney transplant. But when he presented in his late 30s with malignant hypertension, high blood pressure, and when he was diagnosed, it was due to chronic renal failure. His kidneys had already failed. And his kidneys on ultrasound were tiny. They were scarred and very, very small. So he had lost function already. And the nephrologist had said to him, I can't do anything for you except dialyze you or give you a transplant because we've missed the boat. We should have got to you earlier. And my dad had some symptoms when he was a teenager. He had hematuria, blood in his urine after exercise. So he probably had a well-known condition called IgA nephropathy for the medics in the audience. But his GP never took it seriously, and he was never diagnosed at that stage and managed. But we're lucky in MS because in multiple sclerosis we get sentinel events. People present early in the course of their disease when there's lots of brain to preserve. And that's the normal-sized kidney, that's the scarred kidney. And the same thing happens. There's no point in trying to treat this disease years down the line when there's already disability. That's just the wrong approach. We have to treat MS as early as possible to protect reserve. I say that, and there's lots of people in this audience who are quite disabled, I've noticed. That doesn't mean to say we still can't modify it later on in the course of the disease, but we've got less to protect later on. So we need to try and shift the thinking to early effective therapies. And the rheumatologists are ahead of us by about 15 to 20 years. So this is an end-stage rheumatoid joint. So this is the autoimmune disease of the joints. And you can see that hand is destroyed. The good thing about rheumatologists is they can send them off to the orthopedic surgeons and they can put joint replacements. We in neurology can't replace the brain and spinal cord. There is no such thing as a brain transplant or a spinal cord transplant. So we have to protect it as best we can. And the rheumatologists also got these more effective therapies about 20 years ago, and they started treating to target and suppressing activity as much as possible. And you know what they've done? They've reduced the need for joint replacements by over 85%. That's an amazing story. Does anybody know anybody with rheumatoid arthritis in this audience? Okay, 20 years ago, rheumatologists had a terrible prognosis. And nowadays, almost everybody who gets onto the right treatment will have their joints protected. And I think the same thing's happening in MS. If we treat MS the same way rheumatologists treat rheumatoid arthritis, we'll have much less need for walking sticks and wheelchairs in 10 years' time. Actually, at ECTRIMS, there was a wonderful poster from the Italian database system showing that since 2002, that's exactly what's happened. The need for walking sticks and wheelchairs has plummeted in Italy. And that's almost certainly due to the way we treat this disease. And that's also due to the penetration of more effective therapies as well. So I think the wave's going to hit us. We're going to show a much better outcome for people with the disease. So now that we've got brain health, what's going to happen next? So the MS Brain Health Report has united the global MS community in support of its messages and recommendations. This unity is a precious resource and one to be nurtured. So we are nurturing it. It's going to continue. Now we need to look at ways to describe the collective aims and recognize and allow for variation in the diversity of the system. And so what our next thing is to create a quality improvement tool. A quality improvement tool is something that MS practices will measure, and then we can rate each other against each other. And hopefully by doing that, we will see that there's a wide variation in practice and hopefully lift the standards of MS care across the world. This particular technique of creating these quality improvement tools, we call them, have been shown to be very effective in other disease areas, particularly things like diabetes, hypertension, lung disease, anticoagulation therapy for people with atrial fibrillation. So when you actually measure something, you can change it. So that's what we're trying to do. If we start measuring things, we will change things. And then I'm going to activate, well, I want to activate people with the disease because this is what we call the change agents. So this is somebody with the disease, and they're painting their neurologist red. What are you laughing at? So we want people with the disease to become agents of change. And to do that, we want to activate you by giving you power. And the power comes in the form of a checklist, essentially. If you can ask the right questions, you'll get the right treatment. And we want to do it by creating a thing called the MS Advisor. So who knows the best way to get a restaurant to improve its service? TripAdvisor is one, and the best way to get a restaurant to improve its service is give it a bad review. If you give the restaurant a bad review and the owner reads that, he says this is a problem and they improve services. So what we want to do, the same thing, is we want to allow people with the disease to give their neurologists, their nurses and their system a bad review. Now we don't want this to be a naming and shaming, because that's the last thing we want, is to shame individuals, clinicians. So we will allow this, we want this to be anonymous in the sense that a certain clinician, a certain service can keep all the reviews anonymous, but at least get access to them so they can change their behavior. And when they feel comfortable enough, they can allow reviews to become public. And so this is kind of what we want to do, is to allow each centre, each clinician to create their own entry into the MS Advisor. Contact staff, services, a whole lot of information. They can put a picture of their hospital. That's where I work, the Royal London. They can have a little map. And then what happens is individual people with the disease can rate them based on overall rating, how quick they are diagnosing, how they monitor, etc. And so this particular MS Advisor will come after we've got the quality improvement tool in place. And that's basically to make that policy document live, to give it some measurement. People think I'm crazy when I talk about this, but I think this is the way we have to change practice across the world. So our vision is to create a better future for people with MS and their families. Okay, so your voice will help to affect this change, and I'd like to urge you all to be an early adopter. You can go to their particular website, download the report. There's a big document. It's for everybody, but there's a much smaller, easier to read executive summary. And now we've actually got a third document on the site for people with the disease, and it's much easier and crisper to read with some headline things. So please download it and read it. And if you agree with what's in there, you can actually log in and endorse the document yourself, and then you can also subscribe to updates. And the more people we get onto this particular site, the more traction we think this policy is going to have. In addition to that, we would also like to encourage you to adopt a healthy lifestyle. This is not about just disease-modifying treatments. And so I actually set up this thing called the Brain Health Challenge, which is about everybody in this room should be thinking about their own brains, whether or not you've got MS. And there are 4 components to it. There's the MS-specific component, lifestyle, other diseases, and wellness. And essentially, if you've got MS, you need to ask questions about those aspects. If you're just alive, you've got to question your diet. Are you exercising enough? If you're smoking, you should stop smoking. If you're drinking too much, you should cut your alcohol consumption. You should look at your sleep and look at stress levels. And basically, we need to focus on these aspects of our lifestyle. You're going to hear more about that today. Comorbidities, other diseases. You have to actually target all these things. But all these things have been shown to affect the outcome of MS. So if you want to improve your long-term prognosis, you have to prevent this. Actually, I saw some amazing statistics at ECTRIMS. People that have high blood pressure will progress 6 years sooner to an endpoint than people without high blood pressure. So people with MS who've got hypertension that's not managed properly will need a walking stick 6 years earlier than people with MS without high blood pressure. And the reason for that is high blood pressure affects the brain and removes reserve. And so there's a real motivation here to have your blood pressures well controlled. And the same thing applies to diabetes, etc. The question is, who's responsible for this? Is it the MS team or the family doctor? And I think, at least where I work in England, that the GPs are just so overworked they don't have time to do this. So we as a MS service are thinking about how can we help the general practitioners screen and activate patients to monitor these things. Infections, recurrent bladder infections. A lot of people with MS get recurrent bladder infections. There's also been linked to quicker progression of the disease. So we need to put in place services or policies to try and reduce the frequency of bladder infections, for example. All common sense. In wellness, this is something that is going to come to you. So when I was at the American Academy in Vancouver earlier this year, there was a whole day dedicated to neurology and wellness. There's also a breakout zone for neurologists to go and become well themselves. They were thinking about wellness. But I read a report in The Economist about 6 months ago saying the wellness industry is going to be worth more in 2025 than the healthcare industry. Isn't that an incredible observation? So we as providers of healthcare are going to start having to think about how can we incorporate wellness into our practices. And you can see this is all the soft stuff that goes with quality of life. And hopefully today you'll get some more information about what you can do as individuals to improve your wellness. It's essentially how do you improve your quality of life and live better. It's simple as that, because it also impacts on outcome. Well, I'll leave it there. So what I would recommend, I'll put up this presentation online, so you can actually, that's our blog site. If you follow us on the blog, you'll get all this information drip fed to you over time. That's our Clinic Speak site for you to do your own monitoring. That's the brain health site for that document, and that's my Twitter label. Thank you very much. Pardon? So it's ms-resresearch.org. Yes. That's all you need, because if you go to that site today, you can download the presentation. And so you get all this online. That's all you need to remember, ms-res.org. Questions? There's a question at the back.
Yeah. Hi. We have a question that's been tweeted in from an Aileen B. And the question is, quite often the most effective therapies are not accessible by those who are early on in their disease. How do I start a conversation with my neurologist about wanting a more effective treatment than the older interferon I'm on when I have no disease activity?
Difficult, but in England, NHS England have licensed all these treatments based on the European guidelines, and some of the most effective therapies are available at baseline. So that individual, I would argue, needs to monitor their disease to see if they're active. And they need to ask for an MRI scan, because clinical monitoring is not good enough. So in our practice now, we do a baseline scan, and we scan people every single year to see if there are new lesions coming, because we now know that if you're on an interferon, for example, and you have new lesions on your scan, you're going to do much, much worse in the long term. So that individual needs to activate the neurologist to monitor them to see are they responding or not. If they're a NEDA, have no evident disease activity on interferon, and they're doing very well, they may want to stay on that because that's good enough. There are a proportion of people that do extremely well on interferons long term. This is not about getting everybody onto high efficacy therapies. It's getting people onto the therapy that works for them. That's the strategy. So I would argue that individual, if they're doing very well on interferon, may want to stay on that because they know they're responding, and we know that interferons are safe long term.
The medication you mentioned for primary progressive MS, is it available now? If not, what time frame?
No, it's not available because it's a new drug, and so the European Medicine Agency are currently reviewing it. It's been in for about 4 months, so I think they'll get a preliminary hearing at the end of the year, and we should expect a label middle of next year. Then there's obviously the regulatory requirements that happen in Ireland, so I would imagine it's going to be available in about 18 months' time. And I don't want to raise your expectations because even then it may be restricted to a certain proportion of people. And the reason why I want people to monitor their disease is because almost certainly in England we're going to have to be able to show that you've been progressing to get onto that treatment, which is why I need people to monitor their disease. So this is one of the motivations for self-monitoring. Because I think if you're stable, you're not going to be able to get that therapy. So about 18 months, I'd say. But it may come up, there may be trials before then of that drug because the company who's manufacturing it are planning what they call some phase 3B, 4A trials. And so there may be other opportunities to get onto the drug earlier. There's another question in the back.
My doctor told me that my lesions had burned out. What does that mean?
Your lesions have?
Burned out.
That means that you've got just scarred lesions on your scan, and you're not getting any new lesions. But that's also not the whole story, because the MRI scanner is not that good in terms of picking up what's happening under the microscopic level. So we know when people with pathologists look at the brains of people who've passed away, the majority of the lesions in MS are microscopic. In other words, that you can't see them with a naked eye on MRI scan. Whereas on MRI scan only picks up lesions that are 3 to 4 millimeters in size or larger. So an MRI is just picking this up the tip of the iceberg. So you can still have active MS that's occurring beneath the with MRI activity. And that's why we've actually started in our practice doing lumbar punctures, and we measure in the spinal fluid proteins that are released as part of the damage. And if people have got very raised levels of this protein called neurofilament levels, which are released from dying cell, that means their disease is active, and we're actually now putting those people into trials. So our monitoring is getting much more sophisticated, and it's going to get increasingly sophisticated as we get more and more effective therapies. So I think I didn't answer the question. All I'm saying is the MRI hasn't got any new lesions, but that doesn't mean to say your MS is not active. We probably need to look a lot more in more depth to see that. The question at the front here?
The lesions don't appear to be active. It doesn't mean that they're not actually gone, does it?
No, because unfortunately the lesions, a large proportion of the lesions are left behind as a scar. It's called it's a little white blob on the T2.
Don't appear to be having any sort of any signs or symptoms of any sort of that would relate to MS. No numbness, no double vision, no nothing like that at all. But the lesions are still there.
The lesions are still there, and so MS leaves behind a thing called it's a little burnt out inactive lesion, and we can see those remaining on the scan. And that is why when people get scanned, we can still see the scars of previous lesions on their scan.
I appear to be I haven't had a really bad relapse in a good while, and I'm delighted that I haven't. But I'm a little, I must say, I'm scared of it coming back again, because I have had, in the beginning, it was very bad. And it's very bad for everyone who has MS. And I just don't want it to, I suppose if there is a relapse, it will be bad.
Yeah, so that's why we give people treatments, just to try and prevent relapses. So one of the things that you need to be aware of, sometimes when you go onto these therapies, particularly if you've had MS for a while, it stops you having relapses and it stops you having new lesions on your scan, but you're still getting worse. And the reason for that is that the damage in the past, the inflammation in the past, has damaged those nerve fibers that are then programmed to die off in the future. And going on to a treatment now cannot reverse that. That's happened in the past. So those nerves have been primed. And we need new drugs to stop that process from occurring. And that's why we're having neuroprotective trials happening at the moment, to try and protect nerve fibers that are programmed to die off in the future from dying off. And so I see in the future we're going to have combination treatments, drugs to keep away the inflammation, then drugs to protect the nerves from dying off, and then drugs to remyelinate those nerves, and then hopefully drugs to restore function. So we're thinking about that already, all these layers that we're thinking about having to add on. There's one more question, last question.
Do seizures show up on MRIs?
Seizures?
Seizures.
Not with our routine MRI. There's a very special type of MRI scan that can pick up seizure activity.
Yeah.
That picks up increased activity in the area. We don't do that in routine practice. So. So seizures are really, on our routine scans, you don't pick up, we don't use the technology to pick up seizure activity.
Sorry, just quickly, Professor Giovannoni, can I just ask you quickly, you mentioned that cognitive decline is almost inevitable.
No, it's not almost inevitable.
Okay.
I'm saying that's what I'm trying to say to people, that if we treat this disease properly, we will prevent that from happening. That's our aim. It's not inevitable.
But you said in old age as
well. Oh, yes. So unfortunately, cognitive decline is inevitable in everybody with old age.
But I suppose my question was, what about the blue zones, people who live to be 120, 110 in the likes of Japan and Loma Linda, that are really well physically and mentally?
Well, they're well mentally because, but if you interrogate them, they're not that well mentally. They have got quite a lot of cognitive problems.
Okay.
But
and second question really quickly. You mentioned about blood pressure and hypertension and diabetes. Do you think that this points to common risk factors and maybe a treatment? For example, controlling blood pressure, we know that certain medications and certain lifestyle components can do that. Same for diabetes. Do you think that's relevant for MS?
Absolutely relevant for MS. So there is evidence that MS, for various reasons, have a higher incidence of both diabetes and hypertension. So there's slightly higher in the background risk. So this is why you have to monitor for those things and manage them aggressively. And so I actually see us doing trials in the future of taking people with borderline hypertension or borderline metabolic problems and putting them on treatment versus not to see how they do. And so we need the evidence, but the evidence exists outside of MS for this. I work in an institution where the public health doctors want the whole country, everybody in the country, to go into a thing called the poly pill after the age of 50. And based on their modeling, it will reduce the risk of stroke and heart attacks by over 80%, and also reduce the risk of getting Alzheimer's disease because it delays the onset. So there's a big move in the public health sector to treat the whole population with drugs to try and modify these risk factors. I'm not sure it's correct, but we need data for that. So thank you very much.
Thank you very much for your time.
Pleasure. Pleasure.